many different tests available. So the first challenge is selecting the appropriate test, and that can be a big challenge for clinicians since it can depend on a variety of different factors, which test you select, including the age at seizure onset, the severity of disease, other associated features, and even patient insurance is sometimes a consideration. And there have been different algorithms proposed as to which test to begin with, but these are changing. Though it's worth mentioning that the yield of genetic testing for epilepsy ranges from about 20 to 50%, depending on the type of test used. And there are some phenotypic factors that are associated with increased testing yield, which have been described in the literature, including a younger age of onset of epilepsy, so under 2 years, presence of developmental and epileptic encephalopathy, and neurodevelopmental disorders.
There's not one test to diagnose all types of genetic variants as an explanation for epilepsy. There's a limited amount of cost analysis data that suggests that exome is perhaps the best first line test, but it doesn't capture everything. And so there are other tests that need to be filled in if it's negative, and or reanalysis of that data over time.
Another challenge can be the availability of pre-test and post-test counseling, which is really highly recommended and even required prior to performing any genetic test. The family should be informed of the types of results that could be obtained, what are the risks, what are the limitations. And at our center, we are fortunate to have certified genetic counselors who have experience in genetic epilepsy and provide counseling to families. But access to genetic counselors can be an important barrier to implementing genetic testing in clinical settings. And then once a test has been selected and carried out, the interpretation of the results can be a challenge as well. Sometimes, or actually it's recommended to reanalyze the results of exome and genome sequencing every 2 to 3 years approximately, because since research is advancing, these reanalyses may yield diagnostic results in the future. Also, as we mentioned, some types of tests can miss certain types of genetic variants. So the ordering clinician really has to know what kind of variant that they're looking for and what types of variants the test is able to detect. And finally, there are some genetic changes that can't be detected through current standard testing methods, such as some mosaic mutations, which are present only in certain cells in an individual rather than in all of their cells. Some of those are hard to detect through our standard testing methods. And there are also other types of changes, such as epigenetic changes, which don't change the underlying sequence, but are chemical modifications of the DNA that are very hard to detect as well. So all of this needs to be considered before offering a genetic test to a family.
And just to clarify, we are picking up mosaic variants on current testing if they're detectable in blood at the level of the test, but they're rarer mosaic variants are those only present in brain, for example, that aren't detected or missed. And sort of as a big picture summary, the biggest limitations are knowledge amongst the providers who are seeing these patients. We need better training in genetics so that the providers feel comfortable sending testing, as well as support from genetic counseling. Those are really the biggest barriers at a community level, which are more present in tertiary care hospitals.